internal medicine resident, and my boss at the time, the new chief of cardiology, who's actually from UCSF and migrated down south to Los Angeles, said, well, we have this new test. I think it's going to be the mammogram of the heart one day, and then we're going to be using this in asymptomatic risk screening. So he wanted me to do research with him on this test, and I think we have the validation for that concept to be in place, and it's certainly used heavily in certain locales, but we still have a ways to go as far as universal acceptance. I did want to talk about my disclosures. I do a lot of research. I do a lot of clinical research. I get a lot of grant support from the NIH as well as from other industry. My one specific conflict when it comes to coronary calcium scoring is that I do research with a company, General Electric. Nothing to do with the calcium score itself. I do research on their contrast agent, Visipig, but they do own the equipment, one of the 7 manufacturers of CT equipment that can do a calcium score. My other pharmaceutical support is really research that has nothing to do at all with anything that we're going to discuss today. So you heard about this a little bit in the movie. That movie was made by an advocate, a person who suffered a myocardial infarction in Ireland, was very upset that this was not a test that was widely available in Ireland at the time. Since that time, actually, the United Kingdom as a whole has adopted coronary calcium scanning as the first-line therapy in anybody with chest pain. So now the entire country, if you have chest pain in the UK, anywhere in the United Kingdom, you're supposed to get a heart scan first, and if it's abnormal, then you go on for further testing. So I'll talk a little bit more about the guidelines. They were recently expanded in 2016, really dramatically. So this is a picture of the scan, and it really is quite simple. Those little white specks inside the circle represent coronary calcification, so-called hardening of the arteries, thus the term arteriosclerosis. So it literally is the reason why the arteries get stiff and blocked, and the reason why we have heart attacks. So the concept came about from the cath lab, actually, from the invasive cath lab, where we had these procedures, and we could see little specks of calcification under the fluoroscope, and that led to CT scanning of these calcifications, and that led to further evaluation. So we've done very large-scale studies, huge trials that have been done now. This is 25,000 person study I published about a decade ago, looking at just how did people do? What was the survival rates? Going from no plaque at all in the coronary arteries, clean coronary arteries, which we know 50% of Americans have, versus the other 50% that have increasing levels of atherosclerosis. And we can see here, if you start with the score of 0 at the very top, you had an excellent 99.9% mortality, survival, all-cause survival. So you were going to be alive for 10 more years if your score is 0, virtually, and that's 11,000 patients observed for over a decade. As the score goes up, and this is just a volume of plaque, so a little bit of plaque, 1 to 10, a moderate amount of plaque, a score over 100, a volume over 100 of calcified plaque, a severe amount of plaque, a calcium score above 1,000, you can see the mortality goes down significantly, gets worse and significantly as the calcium score goes up. It's a very linear relationship, the lines don't crisscross, it's very clean data. The more atherosclerosis a person has, the more cardiovascular mortality they will suffer. Everybody knows that. That's nothing new. That was discovered in the 1600s. Somebody named Sydenham described it, said, as a man is as old as his coronaries. This is a way of looking into the heart with the radiation dose of a mammogram, and the cost of a mammogram in the United States, about $100, to identify if patients have plaque, and if so, how much? How old are their coronaries? Are they old coronaries that are near occlusion? Are they young coronaries with minimal plaque? Are they clean coronaries with no plaque at all?
So before you move from that slide, that one most dramatic line,
This one
can
down
you
here.
just give us a couple sentences on that?
Yeah, so this is the mortality. This was described in the movie as well. There was a trailer for a movie called The Widowmaker. This Irish benefactor who felt personally slighted created a movie. And it was actually, I think, I wasn't involved in it in any way other than I was one of the people interviewed. But I thought it was very, he had people on both sides of the debate. He had people who didn't believe in the scan talk about it and be interviewed. He had people who thought the scan was useful be interviewed. So I thought it was a very balanced one. It's free on Netflix or Google Play. So it's called The Widowmaker. There's two of them. One with me in it in 2015, not that as exciting as the earlier version of one with Harrison Ford in it climbing K2. So see two different Widowmakers if you want for the price of zero. Anyway, so that curve is what was described as having a mortality rate of about 25%. 1 in 4 patients were dead a decade later if they had a calcium score above 1,000. Now, clearly, this was a decade ago, and this started even 15 years before that with the original cohort, so not all of these patients were treated aggressively with statins, not all of these patients were on aspirin, not all of these patients might have had tight blood pressure control. So we think we can modify these risks, and I'll show you we can. But it's important to recognize that this does still hold true today, that a very high calcium score means you have a lot of plaque in those coronaries, and any one of those plaques can rupture and cause a heart attack. So this was, so I showed 2007, you're 10.4 times more likely to suffer a cardiovascular death. You're 10 times more likely to die if you have a calcium score above 100, what we call moderate plaque. That was not widely accepted as being the truth. It sounded too good to be true. I mean, 10-fold increased risk prediction is much better than anything we've ever had in cardiology. I mean, this is a magnitude of increase in risk prediction. But 2008, this study came out. This was an NIH-sponsored $62 million study looking at how can we predict cardiovascular events. How can we predict in asymptomatic people in the United States, population-based study called the Multiethnic Study of Atherosclerosis, how can we best predict events? And the simple answer was the heart scan. And the simple number was you're 10 times more likely to suffer a heart attack or die if your calcium score is above 100. So in my cohort, 25,000 patients, we showed 10.4-fold increased risk. In this cohort, they showed 10.3-fold increased risk, the exact same number. And that number has been replicated in studies around the world. Person has a calcium score above 100, they are 10 times more likely to suffer a heart attack, stroke, or die over the next 10 years. So it predicts short-term risk, it predicts long-term risk. The newest guidelines that we have in cardiology, 2013 AHA-ACC guidelines on how to assess cardiovascular risk. They said that calcium score is one of the 4 cardinal tests that you can do if the treatment decision is uncertain. That would be the place we would think this test would have a role. People in so-called intermediate risk, because that means we just don't know. Nobody's intermediate. You're either going to have a heart attack or you're not. You're not intermediate risk of becoming pregnant. You either become pregnant or you don't. So there's no such thing as intermediate. So this would solve that problem in the intermediate risk. And for those patients where the treatment decision is uncertain. In other words, I think a patient needs to be on a cholesterol pill, a statin, and they are reluctant because they hear that statins cause diabetes, or statins cause memory problems, or statins cause liver disease. So they don't want to take it. So I tell them we're going to get a calcium score, and if the calcium score is abnormal and positive, I want them to go on the statins and understand that they have heart disease that they need to be treating at an early stage. If their coronaries are clean, I tell them that they're correct. I'll keep them on lifestyle and we'll reassess in a few years. The guidelines go on to say that coronary calcium is likely to be the most useful of the current approaches to improving risk assessment among individuals found to be at intermediate risk. So these are the current guidelines. They say that coronary calcium has the most robust data and that has the best data not only for identifying who is at risk, but also to help with adherence. And we heard about that in the video as well, that patients who see their plaque in their coronaries are more likely to become better patients. And that's the biggest win of all, because as we all know, anybody who's taking care of a patient at any level, it's easy for me to write a prescription for atorvastatin 80 milligrams and say, here's a 3-month supply and 4 refills, and you've got a year's supply, I'll see you in a year. But they have to go to the pharmacy multiple times, they've got to pay for this medicine, and then they've got to take it every single day. And that's where it's not quite as easy on their part as it is for me to write a script. Now, what about this 0 score? How reliable is that? So if I tell somebody they do not have atherosclerosis, their risk should be pretty close to 0 of having something bad happen. And we have great data to that effect. This is 7,000 zeros followed for 15 years. And the negative predictive value, the warranty, is 99.6%. 4 people per 1,000 suffered mortality over the 15 years that we followed them. 4 per 1,000, 0.4%. We had in a bad family history, numbers don't change significantly, but it does go from 0.4% to 0.7%. So we can say with over 99% certainty that if your score is 0, you're not going to suffer a cardiovascular event over the next decade, and you're not going to die of a cardiovascular event over the next decade. And that's really helpful for clinicians and patients to maybe help us focus our attention on those people with higher scores who need more attention. Now, in that MESA study, that multi-ethnic study, we looked at every possible risk marker. I mean, we drew a ton of blood for genetics and C-reactive protein and all these other tests. We did carotid studies. We looked at MRI of the chest. We looked at the ankle brachial index, getting the blood pressure of the arm and the leg, all different ways that have ever been proposed to identify somebody at risk. The blue line that you see buried among all of these various tests, this blue line in here, is Framingham risk. That's just a simple set of questions with a little cholesterol measurement and a blood pressure medicine, and a blood pressure measurement, and that's it. Almost a free assessment. That's how well it performs. It's correct about 60% of the time. How do we improve that? The only way we get it up to move it to more accurate for both sensitivity and specificity is a coronary calcium score. And whether you're interested in predicting heart attacks on the left or strokes and heart attacks on the right, it improved risk prediction by 20%, an area under the curve improvement of 0.20. And that has never happened before in any test in cardiology. There is no test in cardiology that improves the risk prediction by 20%. It's unheard of. All of these other tests, MRI, family history, C-reactive protein, carotid imaging, all improve the risk prediction by 2%, 1%, 0%. This improved the risk prediction by 20%. A huge improvement in who's going to suffer an event. MESA, multi-ethnic study of atherosclerosis in the US, was not the only study to show that calcium scoring was by far the most robust predictor of future events. This is a study out of Rotterdam called the Rotterdam Heart Study, and the exact same findings. The calcium score was by far the best predictor of future events. And we have other cohorts as well. There's about 7 cohort studies, and every single one of them have concluded the same. That coronary calcium, presence of plaque in the coronaries, predicts future coronary events. Not surprising, right? Early disease predicts later disease. A positive mammogram, finding a mass in the breast, is a good predictor of future breast cancer. Finding a nodule in the lung on a CT scanner and having it told that it's early lung cancer is the best predictor of who's going to develop lung cancer. This is exactly the same. This is nothing more than common sense, that if we can find the disease early, we can identify those people at risk. So, how many people does it help us with? Because that's where it gets into being cost-effective or futile. And most of the tests that are listed here are futile because the net rate classification, and you can multiply those numbers by 100 to figure out how many percent of patients it actually helps. If we sent a lot of people to endothelial function tests, an early sign of heart disease, we would improve the risk prediction of 2% of patients. So we'd have to do this 50 times in a row to tell one person that they were not really intermediate risk, but they were high risk or low risk. Futile. If we do ankle brachial index and have our nurses measure blood pressures in the arm and the leg, we change the recommendation on 3% of patients. Not useful. C-reactive protein in the study actually did okay, 7% of people. Family history, 16%. That's pretty good just for a simple yes or no question if you ask the question right. Carotid testing, 10%. But look how many people got reclassified if we did a calcium score, 66% of patients. For every 3 scans we do, 2 people are told either they're high risk and not intermediate risk, they have plaque, they're gonna have a heart attack, or more likely, their score is 0 and they have nothing to worry about at this point. So it's a huge improvement in the net reclassification. How do we classify patients correctly, whether they're gonna have a heart attack or not? And this is all based on truly having an MI or not just is a test positive, but did they actually suffer a heart attack? This is another study in Germany, this population-based study called the Heinz-Nixdorf recall study. Exactly the same thing. It showed that from the intermediate risk in yellow, that if we test patients, about 1 in 7 of them are not intermediate risk, they're actually high risk, but a vast majority, 2/3, are actually low risk, they had 0 scores. So we're misclassifying patients using the risk calculators, and we can refine that risk prediction. But the biggest impact, and you'll see it over and over again in the slides, the biggest impact is to identify people, some people who are high risk, but a lot of people who don't need lifetime statins at this point. They might need it later, and there's no argument that eventually they're going to develop atherosclerosis. But for the next 5 years, for the next 10 years, their chance of having a heart event is 0 or 0.1% per year. This is a brand new study. This came out about a week ago. Hattie actually brought it to my attention. This is a population that I worked with. This is Val Fuster's lab in New York, Mount Sinai, very famous cardiologist, head of our American College of, previous president of the American College of Cardiology and editor of this journal. This is his study, 5,800 patients, free of known heart disease. They went for their ACC, AHA risk classification, and 86% were told they need to be on statins. 86%. So 5 out of 6 people who were just assessed based on their risk factors needed to be on a statin. That's a lot. If they applied the calcium score guidelines, 64% of patients were found to need therapy. So we're saving therapy in 25% of patients. The net reclassification was about 34% between heart disease and CVD. Now, you can say, well, that's all right. That's, saving some statins. Statins aren't that expensive. But you're talking about a population. You're multiplying that 25% of people, 1,400 people in this trial, times the millions of people who are candidates for statins. And this becomes a really, really big deal. This is carotid imaging, not currently recommended by the guidelines, reclassified significantly less people appropriately, but still less people were eligible on statins based on seeing plaque in their carotids than just the risk of the study itself. This study was discussed in detail, some detail in the previous movie that you saw, the St. Francis randomized trial. The ultimate question, can we really improve outcomes if we have a person with a high score? Is this old scar tissue, plaque in the coronaries, and it's too little too late to treat? Or can we do something about it? And the something about it in this trial is not stents, is not bypass. We never advocate any of that for asymptomatic people. The simple algorithm here was, should we put them on a statin or not? A atorvastatin 20 was chosen, not even a very potent dose of a statin. And we randomized 500 people to atorvastatin 20 milligrams. They all had coronary calcium in their arteries, or they got placebo, and they were followed for the next 4 years. And the events were reduced by 30% at 4 years. We had a 30% reduction in events, and heart attack and death as a primary endpoint was reduced by 44%. So we literally cut the heart attack rate in half by knowing their calcium score and putting them on a simple statin therapy. In the background of both of these arms was aspirin. So I always think of statin plus aspirin. Placebo was aspirin alone. It wasn't even really no therapy. And of course, they were controlled for blood pressure and the usual things. If their calcium score was high above 400, a big number of plaque, they actually had even a bigger benefit. Their overall event reduction was 42%, and the number needed to treat to prevent a heart attack was only 16 people. You put 16 people on a statin, you prevent a myocardial infarction or death. That's a really efficient number. Another atorvastatin trial that came out almost the exact same time was called the ASCOT study. Hypertensive plus 3 more risk factors. They had 4 risk factors minimum, high-risk people. They were put on atorvastatin or placebo. The number needed to treat to affect a benefit, 93 people. You have to treat 93 people with a statin for 4 years to prevent 1 event. So having plaque in your coronaries is a much more efficient way of identifying who's at risk and who may benefit from cholesterol therapy. The other randomized trial that was mentioned in the movie was the Eisner randomized trial. This was not an outcome study. This was just looking at common things, like if we tell people that they have a coronary calcium score that's abnormal, do they behave better? Do they perform better? Not a few months later, like a New Year's resolution, but 4 years later. Are they still doing the right things 4 years later? None of these people had known heart disease. When they didn't get a scan, over time, they did have some improvement in their cardiac health. They were enrolled in a study, and that always promotes some better performance for patients. But if they had a positive calcium score, their LDL went down by 30 points. If they had a positive calcium score, their blood pressure was 10 points lower. This is at 4 years later. So this is persistent benefit over time. They were more likely to exercise, start a lipid therapy, start an aspirin tablet, start a new blood pressure medicine, and most importantly, be more compliant with those statins that we understand are important for our patients, but they're actually more likely to take it. So the discontinuation rate was almost 50% lower if they were on a statin, if they had a calcium score positive, as compared to just being told this is a good medicine, stay on it. It actually lowered costs, and this is going to be a recurrent theme in every published paper. Doing the calcium score lowers healthcare costs. And that's been a big barrier because the perception is if we do a heart scan and we find plaque, that everyone's going to go running to the cath lab and getting a stent and getting all these expensive tests. But that doesn't happen in real life, and it's never happened in any published study. And there's 1,000 published studies. I've published 800 studies in this field. I can promise you there is no paper ever that shows that calcium scoring drives up utilization of cath or other studies. And the reason is most of the doctors who are ordering the test understand the test to some degree. They're asymptomatic people. You find some plaque in their coronaries. You put them on the appropriate therapy, what I call the ABCs. Aspirin, blood pressure, cholesterol pill, diet, and exercise. None of those cost very much. They're actually pretty cheap. But the big savings, the reason it's cheaper to get a scan, is not because I'm putting people on blood pressure pills and statins. It's because we're not putting 50% of patients on blood pressure pills and statins, and we're not doing other tests that cost a lot more, like a stress nuclear test, which is very common in our cardiology practice in the United States, or a stress echocardiogram. So procedure costs actually went down because half the population had a score of 0, and there was no justification to do a stress nuclear exam, even though it's in my office and I own the equipment, and it'd be a good revenue generator for my practice to throw them through that machine, which is how, unfortunately, some of my colleagues think when they're seeing patients on a day-to-day basis. And medication costs go down because I'm not starting them on multi-drug therapy to treat their cholesterol abnormality if their coronaries are clean. So it's a common sense approach, but this is 4 years of data. This is not, again, just what happened in the first 3 months after the heart scan. This is 4 years of cumulative data in a carefully controlled trial. So the guidelines, and these are the 2010 version, the 2016 version, which is already published, but it's going to be finalized in November, is going to expand calcium scoring and CT angiography to the entire country for all risk assessment. Literally, if you have a person who has any type of symptom, their first line test is supposed to be a scan and not a stress echo, a stress nuclear, or a treadmill. This is the UK, I have nothing to do with this, this is the United Kingdom, but this is where the evidence is leading us. It's more effective to look into the coronaries and know if there's a problem than to do a functional test and assume that because the functional test looks some way, that there may be a problem in those arteries themselves. So this is what they suggest. If you have a low probability you're presenting with a low probability of having a heart attack at that time, chest pain that sounds atypical or unlikely, the first line test is a calcium scan. And if it's 0, you consider other causes of chest pain. And if it's abnormal, so they have some plaque, and these are symptomatic patients, they go on for a CT angiogram. Now this 10 to 29% has just been expanded to 10 to 90% in the 2016 guidelines. So again, this algorithm makes a lot of sense. And when we think about how we would use this in practice, it's very simple. We do our Framingham risk or our ACC-AJ pooled cohort equation, the new way of risk assessing patients. And if they're low risk, we tell them, hey, you're good, you don't need any further testing. And if you're really high risk, we get them on a statin. I put them on statin and aspirin if they're high risk, and that's what the guidelines suggest, along with diet and exercise. We then, if they're low intermediate or intermediate risk, they're in those gray zones, we do a calcium score. If it's low, if it's 0, calcium score of 0, we call them low risk. No further treatment, follow-up in 5 years. If it's high, you've got a problem, you're on statins, and if it's in the middle somewhere, we still have somewhat of an indeterminate. It risk stratifies, it moves about 2/3 of people either to a high score or a 0 score. So it helps a lot in clearing up that gray zone in the middle.
Dr. Budoff,
Yep.
could you back up just a minute? Where it says e.g. strenuous exercise, could you just give us a couple sentences on that?
Yeah, so personal question, I guess. Family history and strenuous exercise, family history of early heart disease are called out here, and strenuous exercise are called out here. Those are things that we don't promote atherosclerosis. So marathon running, severe distance running. These are things that have been called out in the guidelines as being another risk factor for developing plaque. So I think that's what they're talking about here, is if we're trying to dissuade some of our patients from running marathons. We were just not made as a human being to be marathon runners, and it's a little bit hard on the vasculature. There's been a number of studies that have shown this now.
I don't think that a lot of us know about that, however, that
Yeah.
the strenuous exercise, our big athletes in our population are at high risk due to calcification. So
Right.
that's why you're hearing some buzz.
No, that's all right. So it's not been shown yet in long-distance cycling or swimming. It's mostly been in marathon runners. There's been a number of studies, both in Europe and in the United States. We all know that every marathon that's run, at least one person dies during the marathon of a heart attack, and they have paramedics at both ends of the race. But that's maybe a different thing. People who maybe not ready to run are trying to go 26.2 miles. But the bottom line is that if we look at calcium scores or CT angiograms or invasive angiograms of runners, they have more advanced atherosclerosis than non-runners. So the current recommendations for exercise are 20 minutes to an hour, up to 7 days a week. But most of our marathon runners far exceed 7 hours a week of exercise, and probably maybe a little bit hard on the vasculature. There's a lot of theories. Chronic inflammation from infection, from the joints, the literal physical just up and down movement of bouncing for 26 miles at a time might cause shear stress and other problems in the arteries. there's a lot of theories. I don't think we fully understand it, but it is making its way into guidelines as we speak.
Could you comment on the fact that the NICE criteria are using a 400 cutoff and you have 100 for this?
Yeah, so, so this is partially based off of the newest iteration, but you're right. The NICE guidelines